This is part 2 of concurrent disorders affecting pregnancy. The immune complex disorders. These are things like lupus, antiphospholipid syndrome, and rheumatoid arthritis. Most of these women come to the pregnancy with this disorder. Lupus, if it's well controlled, we can expect a pretty good outcome. But we have to monitor her renal function because she may be renally impaired. Now, antiphospholipid syndrome, if they actually get to us in antepartum or in labor and delivery, this woman is doing a very good job because many of these women have a difficult time conceiving. They have recurrent miscarriages. Now, if we do see them in antepartum, in labor and delivery, and in postpartum, our biggest worry is that they will have a deep vein thrombosis or throw a pulmonary emboli. So be on alert for that. The fetuses of women who have antiphospholipid syndrome are at risk for having intrauterine growth restriction. We abbreviate that IUGR. The mother may be at risk for developing preeclampsia earlier than what we would expect, and we would anticipate preterm delivery in this patient. So all of these women are put in that high-risk category. They are coming into the OB office or going to a perinatologist much more frequently than that healthy woman who does not have this. Rheumatoid arthritis is a little bit different. Many women who have RA go into remission throughout the pregnancy. They absolutely love being pregnant because their joints are no longer red, hot, swollen, and painful. The medications that they're taking may need to be modified. We do not want her taking methotrexate because this has an adverse effect on the fetus. We also do not want her taking many of the immune modulator biologics. So we need good preconception planning so that we can make medication adjustments. Well, we don't make it, the obstetrician will. Now, the interesting thing about RA is that 90% of these women will have an exacerbation of their illness within 3 months of delivery. And it can be pretty bad. So we will resume all of the medications that they were on before they conceived. They're going to be resumed. It may not be done while she's on the postpartum floor, but if you're working in an OB office or you're working in a OBGYN clinic, this patient would come in within a couple of weeks and the obstetrician would say, you know what, you need to go see your rheumatologist, get back on your meds. HIV in pregnancy. I am not certain what the population of HIV positive is in Orange County. I know in Los Angeles County there is quite a bit. Keep your antenna open. There's probably many more than you would think. The goal of in pregnancy when someone is HIV is to try to avoid transmission to the baby. And so the best way we can do this is have the mother take the antiretroviral medications. If they're not already on these medications, then they are going to start them. And it's best if we can get these on board between 14 and 34 weeks to reduce transmission to this baby. So I've given you what the dosage is. You don't really have to know it, but just know that we do have things that we can do to help this fetus. Now, when they get admitted to us when they're in labor, we are going to give the IV zidovudine throughout labor until delivery. And then this, you do need to know what the dosage is, 2 milligrams per kilo the first hour, and then we give them 1 milligram per kilogram per hour until they deliver. We prefer to deliver this baby by a scheduled C-section to reduce the transmission to the fetus. So this may be a woman who comes in at 39 weeks for a scheduled C-section. Now remember, HIV is private information. It may or may not be brought over with that prenatal record. You ask the OB or you ask the patient, well, why is she being sectioned? She's a primate. Because we're going to C-section her, and that might be all that there is. So another reason why we wear gloves, but remember, you can't get HIV just by touching skin. It has to be body fluids. An HIV positive woman should not breastfeed their baby because HIV is present in the milk. Now, there is some controversy about when do we start the baby on the meds, and if she's on the meds, can she breastfeed? So pretty much we're just saying, you know what, this is one kid that's going to do bottle feeding, and then they can discuss that once patient's discharged. Now, our neurologic disorders are a little bit more difficult to predict on what's going to happen, because sometimes seizure activity will increase because of the stress of the pregnancy. Some of them are going to decrease, some of them are going to be the same, and we cannot predict who that is going to happen to. Because if the blood volume changes, or if this patient is vomiting constantly, or because of decreased gastric motility, as well as weight gain, this is going to affect the drug levels of any of the anti-seizure meds that this patient is on. So if you think that the drug levels are greatly reduced, what's going to happen? This woman's going to have seizures. If she's vomiting all the time and she's volume contracted, she's not going to have any seizures, but she might start having side effects of these anti-seizure meds. So I've listed on here some of the medications that are considered to be teratogenic or harmful to the baby. So Dilantin, which we're not using all that much anymore, that's one of them. If we give phenobarb in the third trimester, that can be harmful. And carbamazepine, that is also considered to be teratogenic. When this patient is admitted to antepartum, labor and delivery, postpartum, we want to have the same seizure precautions in place that we would have for any person who has a history of seizures. But you have to elicit this information when you admit them and you get their health history. Depression. A lot of people talk about postpartum depression, but remember that women have depression and then they become pregnant. This is not postpartum depression. This is not pregnancy depression. This is just your plain old standard ordinary depression. So similar to the anti-seizure medications, many of the antidepressants may be harmful to the fetus. And it can cause congenital heart defects, it can cause pulmonary hypertension, it can cause problems with brain development. Now, when you look these drugs up, many of them are category C. So what is a category C drug? That's where when you look at the pendulum of justice is the benefit to the mother versus the risk to the fetus. So it just kind of swings both ways, and then it balances where we have to see, well, if we take her off her meds, is she going to be suicidal? Well, what good is that going to be to this fetus? Versus, well, you know, in rats, when we gave 1,000 times the dose, this may have happened, but we've never seen it in a human. Well, I think I would rather have this person on the medication. So this is sort of the thought that goes into this. It's much more scientific than that, but this is the way you can remember it. Now, Paxil is considered a category D drug. So if a woman conceives, comes in, tells us she's on that, this is a woman who needs to be taken off the medication. And if it's in the first trimester, exposure, then we're going to get a fetal echo throughout the pregnancy to look for congenital heart defects. So remember, we must weigh the benefit to the mother versus the risk to the fetus. We also want these women to continue in counseling or any time of psychological or psychiatric therapy that they have been getting even up to the time that they started being pregnant. Now this next slide is quite interesting. I recommend that you pause it just so that you can look to see which drugs are okay and which ones are not okay. You don't have to memorize the list, but just have an idea. So the best antidepressants that we use in pregnancy are sertraline, citalopram, and fluoxetine. And the only reason that these are recommended is because they are the ones that have been studied the most. It doesn't really mean that it's better than some of the ones that are less studied. It's just the less studied need to be studied. So this ends part 2 of concurrent disorders in pregnancy. So move on to the last one, part 3.